Hello and welcome to the Parkinson's Foundation Wellness Wednesdays webinar. The Parkinson's Foundation is a dedicated non-for-profit organization committed to enhancing the lives of those living with and impacted by Parkinson's disease. We focus on improving care and advancing research, ensuring that all our efforts are closely aligned with the needs and priorities of the Parkinson's community. Today's webinar focuses on the introduction and basic overview of Parkinson's disease. PD varies from person to person and changes over time. This program will provide practical daily living tips to empower you to take charge of your health and to navigate the challenges of living with PD. As a reminder, today's program is sponsored by Biogen's Luma study. Thank you, Biogen Luma Study, for your support of our mission. Also, join us this November for our Care Partner Summit webinar series designed specifically for those supporting someone with Parkinson's. Whether you're new to the role or have been caring for a while, these webinars will offer valuable strategies for managing Parkinson's, maintaining strong relationships, and navigating daily challenges with confidence. Our expert panelists will share insights and practical tips to support you every step of the way. We are hosting 3 webinars throughout the month of November. You can sign up for all 3 or just the one that speaks the most to you and your needs. You can learn more details about this program by visiting our website, parkinson.org/summit, or you can take out your smartphone and scan the QR code on the screen. We hope you will join us for these webinars designed specifically for those supporting someone with Parkinson's. And now to begin our formal presentation, I would like to introduce our presenter for today, Dr. Matthew Burns. Dr. Matthew Burns is an assistant professor in the Department of Neurology at the University of Florida College of Medicine and a member of the Norman Fixel Institute for Neurological Diseases. Dr. Burns received his medical degree and doctorate degree from the University of Illinois College of Medicine at Chicago. He completed a neurology residency at the University of Chicago Medical Center and a movement disorders fellowship at the University of Florida. Dr. Burns is a board certified in neurology by the American Board of Psychiatry and Neurology and sees patients with movement disorders, including all forms of Parkinsonism and ataxia, as well as dementia. His research interests including the interaction between aging and neurodegenerative disorders, molecular mechanisms of ataxia, and novel therapies for these disorders. Dr. Burns, thank you so much for sharing your time and expertise with us. Welcome.
Thank you very much, and I appreciate the opportunity. Let me fire up the... So can everyone see the presentation?
No, we are not seeing your screen.
Okay. How about now?
Perfect. Thank you.
Great. So in the introduction, it was mentioned that Parkinson's disease varies from patient to patient. That's certainly been my experience as a clinician. As a result, I'd like to try and cover the waterfront as far as common patterns of disease, treatment, and how to manage it if you're a patient, and also if you're a family member. But also, I want to make myself available for question and answers, because I think there's so much variety in the way that people come to this disease and how they experience it, that often people have questions that are different than the sort of standard initial approach to disease. And I want to give them a chance to answer those questions. And then if one person has such a question, my guess is that other people have them too. So we're going to split this time up sort of half and half, so that we can get those questions answered. You're welcome to wait until the end of my prepared remarks to ask questions, by either raising your hand, or you can put those questions in the chat, and then those questions will be compiled, and we'll try and address them at the end. Okay. So I want to start with really a Parkinson's disease 101, what you and also your family should know about the disease. I have no relevant disclosures. And my goal is severalfold. First, I want to give you some sense about the causes of the disease and who tends to get it, and then understand the common motor and non-motor symptoms of Parkinson's disease. I'll explain a little bit more that distinction. Give you some sense of the treatment options, including non-medication based treatment options, including exercise for symptom management. Learn the importance of having a multidisciplinary team. And what that means is not just a neurologist, not just a movement disorders trained neurologist, but other folks who can help you manage this multifaceted disease. And then give you some sense of good resources and support to go to as you go along this journey. Because I think often understanding the disease has to do with having a conversation with this multidisciplinary team and learning about facets of the disease as they come up. Okay, so what is Parkinson's disease? So it's a progressive brain disorder, and currently there is no cure, but symptoms can be quite well managed for a fair amount of time, and I'll talk a little bit more about that. Parkinson's can affect movement. The classic presentation is slowness, stiffness, and tremor, but it affects mood, thinking, and many other non-motor symptoms that are not tremor, slowness, and stiffness. And those can be treated effectively as well. And that healthy lifestyle choices can dramatically affect quality of life and may also affect disease progression and how much the disease progresses. So I don't want to get too technical, but I want to give you some sense of the current concept around the pathology of the disease and how clinicians and researchers think about it. So in the Parkinson's disease brain, there is an association between accumulation of a protein called alpha-synuclein and disease progression. So with time, alpha-synuclein progresses or spreads from brainstem areas, represented in the middle here, sort of the stalk of the brain, out into the cortex. And this is just a cartoon picture of a sagittal slice of the brain, sort of right through the middle of the brain. And as aggregates or clumps of alpha-synuclein build up in first the brainstem and then the cortex, people develop motor symptoms and then subsequently cognitive symptoms. And because you may run across these terms, those aggregates or clumps are described as Lewy bodies, just because Friedrich Lewy was the first who described seeing them on brain tissues. And they're clumps of protein that includes alpha-synuclein, but includes other stuff as well. And you see these aggregates in the brainstem and then also in the cortex. This is just two different ways of staining for the same aggregates. That's why they're different colors. So you'll hear alpha-synuclein as the main protein associated with disease, and these Lewy bodies as the sort of aggregate that alpha-synuclein is found in as you read about Parkinson's disease. So I want to introduce you to those terms. As far as who gets Parkinson's disease, it's estimated that about 1 million people in the United States have the disease currently, and it's the second most common neurodegenerative disease in the United States, and it's the fastest growing neurodegenerative disease in the United States and worldwide. It can affect anyone regardless of race, ethnicity, and gender. So there is a slight male predominance in Parkinson's disease, but many women get it, and there doesn't seem to be an association with race or ethnicity. There's a fair amount of young people who get it, and that is true whether you have a genetic cause for Parkinson's disease or not. But the average age of onset is late 50s to early 60s on average, with a wide spread around that average. Early signs of Parkinson's disease, as I mentioned before, the common motor symptoms are a tremor, and often specifically that's a rest tremor. So a tremor that You can see if you're, say, using utensils or holding a cup, but is more noticeable at rest and usually more noticeable with distraction. So often I'll ask patients, do you have a tremor? And if they say yes, I'll say, is it worse when you're just sitting in the passenger seat of a car or watching TV? Or is it worse when you're using your hands? Usually Parkinson's, not always, usually Parkinson's patients say, well, yeah, and you know what, I notice it when I'm paying attention to something else. And if I think about the tremor, I can make it stop for brief periods of time. People also notice trouble moving and walking. Usually slowness is a common motor feature, shuffling of gait, slowness of movement. Sometimes spouses will notice a masked face or just sort of general slowness. Sometimes stooping or hunching when walking, or a lack of arm swing when people walk. Those are the common motor symptoms. But people notice other symptoms as well, including trouble sleeping. Sometimes people will act out their dreams at night, punching and kicking, thrashing around. They themselves don't remember, but their bed partner certainly does. Often a soft or low voice, sometimes dizziness, sometimes constipation or loss of sense of smell. And the constipation, sleep problems, and sense of smell sometimes happen years before the motor symptoms start becoming obvious. Often clinicians will talk about a Parkinsonism prodrome, in which those three symptoms, the sleeping problems, loss of sense of smell, and constipation, start becoming noticeable years before a tremor starts or a shuffling gait starts. As I mentioned to you before, although synuclein, that protein synuclein, is associated with disease, there's still a debate in the field about whether it causes disease or just comes with the disease. And it's generally thought that many things can cause the symptoms of Parkinson's. So, for example, certain environmental toxins, like heavy metals, or pesticides, like organophosphates, have been associated with them. Sometimes head trauma, and Muhammad Ali is a perfect example of this, where repeated head trauma can damage the cells that make the neurotransmitter dopamine. That leads to can lead to Parkinson's disease. And then certain rare genetic disorders can also lead to Parkinson's disease. So what's happening in the brain in Parkinson's disease? And I think this is an important concept to understand because it informs how we tend to treat the symptoms of the disease. So in Parkinson's, you can sort of think of Parkinson's as a dopamine deficiency. So if, for example, you had a B12 deficiency or a vitamin D deficiency, I would give you more B12. I would give you more vitamin D, and that would supplement the lack of B12 or vitamin D you have, and then you would be adequately supplemented. In Parkinson's disease, at least to a first approximation, it's quite similar. There are cells in the brain that make dopamine for the rest of the brain. And in Parkinson's disease, those cells are not making enough dopamine for what the brain needs. And that, by and large, produces the symptoms that I've just described. Problems with tremor, with slowness, speech, sleep, even cognition and mood can be the result of basically a dopamine deficiency. And I say that's an important concept because as a result of that, the way we treat Parkinson's is largely to supplement with a type of dopamine called carbidopa-levodopa, which is the standard med that I'll talk about further in a little while. But although it's not perfectly true that Parkinson's disease is merely a dopamine deficiency, to a good first approximation, that's a reasonable sort of summation of the disease and informs a lot of the treatments. Okay, so what should you know about the symptoms? So first, although the core motor symptoms, tremor, slowness, and stiffness, are the things that are used to make the diagnosis and are usually used by clinicians to identify how well the meds are working or how the disease is progressing, there are many systems, biological systems, that are affected in Parkinson's disease, including mood and thinking. So patients can have, as I mentioned before, sleep problems, depression, anxiety, apathy, insomnia, a particular kind of cognitive symptom where patients have difficulty with either word finding or following multi-step instructions, and that's somewhat distinct from other forms of cognitive impairment like Alzheimer's disease or frontotemporal dementia. And then the symptoms vary significantly from person to person. So there are some people whose main symptom is tremor, other people who have no tremor at all. They both have Parkinson's disease. Some people whose walking imbalance is the main symptom for them, other people where the cognitive symptoms or the mood symptoms are predominant. And so that's important to remember, because as you read about Parkinson's disease online or talk to other people in support groups, they may report very different sets of symptoms than you have or will have in the future. And so getting a sense of what disease progression will look like for you may or may not be informed by what other people are going through. Okay, so we make this broad distinction between motor symptoms and non-motor symptoms. So the motor symptoms are that tremor or that shaking of a hand or foot, sometimes in the jaw. It's often the most recognizable symptom, the symptom that people notice the most or are preoccupied with the most. But as I mentioned before, not all people with Parkinson's have a Parkinsonian tremor. And the particular characteristics of them are that the tremor is more noticeable at rest, although you can notice it when you're using your hand, and it's more noticeable with distraction. Slowness or trouble with movement, movement disorders doctors will call that bradykinesia, which is just slow movement. Usually the way that's assessed in clinic is that I have a patient do rapid alternating movements, say tapping their fingers or opening and closing their hands. And the pattern I tend to see is that those movements are slower and smaller, and the amplitude of the movement gets smaller over time. The way this tends to manifest is a patient will say, you know what, doc, if I'm writing longhand, a long sentence, I start out okay, but then the words get smaller and smaller and smaller as I go along. So that's a example of that slowness and the decreased amplitude or decrement over time. People get a particular kind of stiffness called rigidity, and I can feel that on exam if I move someone's arms, and if I distract them by telling them to open and close a hand or count backwards from 20 by threes, that stiffness will get worse. And then people have trouble with walking and balance. So people will tend to shuffle. The length of the stride gets short, tend not to swing their arms. And when they tend to turn in slow shuffling steps. People also describe balance problems of various types as well. So these are the core motor symptoms. And to make the diagnosis of Parkinson's disease, you need two of these four symptoms. So as I mentioned before, if you have slowness and balance problems, even if you don't have tremor or stiffness, that's sufficient to get a diagnosis of Parkinson's disease. The non-motor symptoms are a much more significant list. So people can have depression, anxiety, and to some extent, the depression and anxiety can be responsive to dopaminergic medications. Also, people can experience apathy, sometimes anxiety and apathy at the same time. And again, those can be treatable either with antidepressant medications, stimulants, or an adequate dose of the dopamine medication. People describe thinking problems, trouble paying attention, following multi-step commands, trouble remembering words. People will say, there's a word on the tip of my tongue, and then 2 minutes later it comes to me, but I can't think of it in the moment. And then some people have soft speech. They have trouble staying asleep or falling asleep. Sometimes they describe fatigue during the day. And occasionally people will have hallucinations or delusions. The hallucinations tend to be visual hallucinations. People will either think they see something moving in their periphery and they look and it's just an end table, or they'll see people or animals. Some people will be convinced that there's someone in the house, so there's a presence. And then constipation is a significant issue for many Parkinson's patients. And many of these things are treatable. So how is it diagnosed? Well, I've mentioned this before. It's diagnosed largely by seeing a neurologist, ideally someone who has either experience seeing Parkinson's patients or who has gotten specific movement disorders fellowship training. And that person applies or assesses the patient for those motor symptoms to see if they meet diagnostic criteria. So that's the main form of diagnosis. There is no blood test or brain scan that is more accurate, more sensitive and specific than seeing a clinician with relevant experience or training. There is a DAT scan, which is a type of brain imaging in which they give you IV in your arm, and then that IV dye binds to the part of the brain that is affected in Parkinson's. And if there's reduced binding, that's suggestive of Parkinson's disease. Now, why is this not thought of as a diagnostic tool, but only a supportive tool for diagnosis? And that's because the imaging test is not any better at making the diagnosis, ruling in or out the disease, as compared to seeing a clinician. And so sometimes, in some cases where the diagnosis is not clear, the symptoms are not classic for Parkinson's, sometimes we'll get a DAT scan as a kind of a second opinion. But because the scan, at least in its current form, is not more accurate than seeing a clinician, still the clinical visit is the standard for making a diagnosis. Okay, so let's say you've seen that clinician and you meet those diagnostic criteria. Maybe you have some of the prodromal symptoms. You're acting out your dreams at night. You've got some constipation. Maybe you've got a little bit of anxiety, even though you're not historically an anxious person. So then probably what the clinician will say is, do you want to start therapy? And often the reason why it's framed in those terms is because all of the medications that are made available for patients with Parkinson's disease are symptomatic medications. So what that means is that the meds help with symptoms, they improve symptoms, but they don't change the progression of disease or the course of disease. So they're symptomatic meds only. That's different than if you went into a doctor's office and you had a bad infection, right? If you had a bad infection, the doctor would say, you need to take this antibiotic. You have to take the antibiotic so that the disease will go away, namely the infection. And if you don't take the antibiotic, the disease will get worse. That's not true in Parkinson's disease. Whether you take meds or not, the disease will progress at the same rate it was going to anyway. And so the medications are largely meant to help the symptoms that you care about, that are painful or embarrassing or impairing in some way. And so that's the standard by which physicians help patients make decisions about treatment. And so, for example, I have some patients who have a relatively subtle Parkinsonian tremor, but it matters a lot to them. They speak publicly, for example, or they work with their hands. It's very important that their tremor be well controlled. And so we're aggressive with medication management. I've got other patients who have a big honking tremor and they don't care, so I don't care. And so the treatment, because it's symptomatic, is individualized. And if you see a movement disorder specialist, often the discussion will be, what are the symptoms that bother you? Do they bother you enough to take a pill on a regular basis? And is that pill working to help the symptoms you care about? So it's a much more collaborative dynamic than just going to see a doc about a bacterial infection. So I've already started talking about medications, but I want to back up for just a minute because before I start talking about medications or symptomatic management, I really should talk about the things that have the best evidence for slowing progression of disease, and that is exercise. I know doctors are always harping about exercise, but in this case, there is strong evidence to suggest that regular exercise can slow progression of disease and help with Parkinsonian symptoms significantly. So when I say exercise, what do I mean? So number one, it's usually a combination of different types of exercise, but number one, it should be something that you enjoy doing, that you're willing to do regularly. That's rule number one. Number two, at least in the studies that have been done about exercise in Parkinson's disease, the first thing you should try and implement is cardiovascular exercise that is of mild to moderate effort. So this would be something like a brisk walk or riding on a recumbent bicycle, where while you're doing that, you can carry on a conversation, but the person you're talking to should know that you're exercising. So for example, say I'm on a brisk walk and I'm talking on the phone, I should be able to talk to that person, but I would be taking breaths in between sentences as I talk to that person. That's the level of effort that you want. Nothing more vigorous than that. And you want to be able to do that at least, I would say, 180 to 200 minutes a week, which is about 30 minutes a day. The form of that cardiovascular exercise does not matter. It can be water aerobics, can be recumbent bike, can be rock steady boxing, can be a brisk walk, whatever you enjoy doing. So that's standard number one. In addition to that cardiovascular exercise, which has the evidence base, I think some form of resistance training or strength training, some form of balance training, flexibility training is also good. And that can come in a myriad of forms. Tai Chi, yoga, Pilates, rock steady boxing, whatever you enjoy doing. But come up with a routine that works for you where those basic building blocks are there. Mild to moderate exercise for about 180 to 200 minutes a week, some strength training, some balance and flexibility training. This will make a big difference in your quality of life and progression of disease, and really is the cornerstone of Parkinson's management, because it's the only thing that has been shown to slow progression. If it were a pill, it would be like $1 trillion drug. But everyone with Parkinson's disease should be exercising in this way. And then nutrition. Nutrition has several benefits. Number one, it helps with general health. It helps with the constipation that many Parkinson's patients have, and specifically regular water, regular fiber intake with fruits and vegetables. It also can help significantly with mood and sleep, which are issues that Parkinson's patients have. And so I would say even more than a pill for constipation, even more than a pill for mood or sleep, regular healthy diet can make a huge difference for Parkinson's. So really, once the diagnosis is made, it's exercise, nutrition, and then you move on to talking about pills. I think the best way to get Parkinson's care throughout the course of disease is a multidisciplinary approach. It's something that here at University of Florida we employ regularly and take very seriously, and I think it can have a tremendous amount of effect because the disease is multifaceted, and so you want to, at least at certain points in your care, be talking to different kinds of providers about how to manage the disease. So certainly that may include a movement disorder specialist or a general neurologist with experience in Parkinson's disease. Could be a nurse, a physical therapist, an occupational therapist, for advice about exercise, for balance and gait, for other issues, a speech and language pathologist, social worker, a psychiatrist and psychologist, and sometimes a pharmacist to advise about how medications interact with other treatments you're getting. But this sort of care plan, you don't need to see all these people every 6 months, but you want to have access to some of these interdisciplinary professionals, I think, for best care. Okay. So I've mentioned already the kind of doc you probably want to see. And then as far as your impression of the doc, because the disease varies so much, because there are a bunch of issues that come up with motor and non-motor symptom, diet and exercise, you want to have a good dynamic with the doc. Be able to ask questions, feel like you're being heard. And that may mean shopping around a little bit. That's fine. You shouldn't feel bad about that. You want to connect with the person you're working with, so that you feel like you're getting your questions answered. There is a hotline here that the Parkinson's Foundation offers, and that can give you some good information about the kinds of docs who have experience or relevant training. Okay, so symptom management. So as I mentioned before, reasonable to consider Parkinson's as a dopamine deficiency. And so largely the medications are focused around some form of dopamine at regular intervals throughout the day to maintain an even and sufficient level of dopamine in the blood and as a result in the brain, including in addition to exercise, physical therapy, counseling, and the rest. We'll talk some about surgical options for the motor symptoms in a little while. So by far, the most commonly used medication is what's called carbidopa-levodopa. The reason why it has this ridiculous name is that it's two drugs in one. The levodopa listed here is a precursor to dopamine that gets broken down into the active form of dopamine. The carbidopa is a med that blocks peripheral breakdown of the levodopa in your gut. So if you were to just eat levodopa without carbidopa, you'd get wildly nauseous and probably throw up. And some people have some of those symptoms anyway, but the carbidopa, the first name in the drug, is meant to either block that effect, that side effect, or at least limit it. There are other drugs as well, dopamine agonists like Mirapex or Pramipexole, MeO-B inhibitors like Rasagiline or Selegiline, COMT inhibitors. All of these function very similarly. They basically, they either mimic dopamine, so the agonists are basically synthetic dopamine. The MeO-B inhibitors block the enzyme that breaks down dopamine, so it maintains natural dopamine in the brain for longer. And the COMT inhibitors do a very similar thing. So again, the theme here is getting you back to the amount of dopamine that your brain needs to function normally. So this diagram is a little bit busy, but I think it gives you a good visual of how Parkinson's is managed with dopaminergic meds of some form or other. So at the beginning of disease, early stage disease, the left part of this slide, as you eat the carbidopa-levodopa, the amount of dopamine in your blood goes up, and then it starts to go down again until you take your next pill, up and down like that. But because you don't have you have a fair amount of tolerance for increased or decreased dopamine because your brain is able to store the additional carbidopa-levodopa that you eat, your symptoms are relatively well managed. Whereas as disease progresses, that window of good management narrows, gets smaller and smaller. That's the purple cone that moves left to right. And as a result, as you keep taking the carbidopa-levodopa and the medication goes up and then down, you start getting into this area where at the peak dose of carbidopa-levodopa, you get dyskinesia, which is that abnormal wiggly movement. And that's caused by the carbidopa-levodopa spilling into other dopamine receptors that are not the main dopamine receptors that help with symptoms and can cause those other side effects. And then also wearing off. You also, as you progress in disease, will get a delayed on. So you take your pill at the bottom of the dose, but it takes a while for that med to kick in. That can be because you need to get a higher blood level to get good symptom management. Could be because of GI symptoms. And so this, I think, gives a decent visual of what people experience over time, where people say, you know, doc, I've been taking 2 tablets of carbidopa-levodopa 3 times a day, but 6 months ago or a year ago, I was fine, but now I notice an hour before my next dose is due, I start to wear off, or now an hour after I take my pills, I'm starting to fidget a little bit. My wife notices. So this is the pattern of symptom management in Parkinson's disease. I want to stay on this slide for just 2 more minutes because some patients will come in to me and they'll say, well, doc, I don't want to take more carbidopa-levodopa because I've heard the med causes dyskinesia. And I've seen Michael J. Fox on TV and I don't want to be like that. In truth, the med doesn't make you have dyskinesia if you weren't going to have dyskinesia anyway. Dyskinesia is the result of an interaction between the med and disease progression. and this has been studied with some rigor, if you look at groups of patients, Parkinson's patients, who start taking carbidopa-levodopa early in their disease versus people who wait and take it later, there's really no difference in rates of progression or when people start getting dyskinesia. And so that suggests that the med itself is not the thing that makes you start having dyskinesia. It's how the med interacts with disease progression, which is happening underneath all the time. So there really is no reason to delay taking the amount of med that you need to get the symptom management that you want. Additionally, people will say, you know what, I don't like pills and I don't want to become dependent on the meds. I know some meds, there's a dependence, you become addicted to it. No evidence that that's true for carbidopa-levodopa. Certainly, over time, as disease progresses, you may need higher dose to get the same symptom management, but there's not a dependence. You don't need to take more meds because you've been taking meds already. It's because of the underlying disease progression. Okay, so we've talked about how you make the diagnosis. We've talked about exercise and nutrition as being mainstays of treatment, and that there are a variety of types of meds, but the main theme is most of the meds are used to treat that dopamine deficiency and supply sufficient dopamine for the brain's use. When patients' symptoms are no longer adequately managed with medications, or they're taking pills multiple times a day, or they're having a lot of off symptoms despite taking multiple meds, sometimes people will start talking, physicians will start talking about surgical management. And there are several surgical options. One is called deep brain stimulation. It's sort of a pacemaker for your brain, where we place an electrode in the part of the brain that is sending abnormal signals to produce these symptoms. We send an electrical current through that electrode. The electrode runs under the skin to a battery pack in your chest, just like a pacemaker. And then we can program the signals of that electrode to block the symptoms. That can be very effective for managing the tremor, the slowness, and the stiffness. It is not so effective at managing many of the other symptoms I've mentioned, the mood-related symptoms, the constipation, and sleep-related symptoms. Additionally, there are some risks with deep brain stimulation, including, not with all patients, but with some patients, problems with balance, problems with cognition, and problems with speech. And so if you're being considered for deep brain stimulation, or you yourself are thinking about or asking your doctor about it, you want to go to some place that evaluates your symptoms and potential risks for such a surgery, so that they can give you a clear sense of what the risk benefit for you would be. Duopa is another surgical therapy. It is a carbidopa-levodopa intestinal gel that's delivered through a tube in your abdomen into the intestine. It's also used to treat motor symptoms, really any symptom that is currently responsive to oral meds. And it can be very effective for patients who are at high surgical risk and would not tolerate deep brain stimulation, or who have other complications that make DBS not a great option. And also for patients who have really big swings between on and off, or who are very brittle, where they get great response from the meds when the meds work, but it's very unpredictable, and their off time and off symptoms are really bad. So overall, when you're thinking about managing Parkinson's disease, before jumping into pills or discussing surgical management, you want to take a step back and say, what are the things that matter to me? What are the symptoms that matter to me? And what's the kind of care that would help me meet these goals of treatment? I think that's number one, especially because many of the treatments are symptomatic, and because disease progression is different for different people. As I mentioned, you want to find someone who has significant experience in Parkinson's disease, and ideally be treated in a multidisciplinary setting. And you want to find someone to talk to. The Parkinson's Foundation, other foundations are very good at offering patient groups and caregiver groups. You want to get plugged into those if you can, Facebook groups or whatever you have access to. You really want to talk through these things that you're going through. I think it can make a huge difference as far as your experience. You want to build those habits, exercise, diet, and a regular medication regimen if necessary. And I think thinking about care in a more broader, holistic way, I think will produce better quality of life, probably slower disease progression, and it's sort of a more fulfilling experience. There is a fair amount of Parkinson's research going on at the moment, and probably the best way to get plugged into that is either, even if you're getting good care from a local neurologist, go see someone in an academic center at least once so that you're plugged into the clinical trials that may be going on in that academic center. You can look at clinicaltrials.gov. That's a clearinghouse for all currently enrolling and listed clinical trials for Parkinson's disease, or call the Parkinson Foundation hotline, and they're very good at giving you information about what clinical trials are going on where. Okay, so key takeaways. The symptoms can be managed effectively and for a long time, but the symptoms vary, and those symptoms can vary with regard to motor symptoms and non-motor symptoms. And so you really want a multidisciplinary approach that's personalized, where you're able to explore the symptoms you have and the best ways to manage them, and get plugged into a network of people, support network through family and friends, and a network of people who know Parkinson's disease. I think those are key steps to good care. There are a bunch of resources online of varying levels of quality. And I'm not going to tell you not to Google stuff. That's your prerogative. But I would say that consistent and physician-reviewed information about Parkinson's disease is important. And that's available at the Parkinson's Foundation website, also Michael J. Fox Foundation website, parkinsons.org, and through the helpline email and phone number. So you can Google stuff, but always take that with a grain of salt and cross-check with the resources that I've mentioned if you're trying to learn more about the disease. So with that, I will stop and hopefully open it up to whatever questions you guys might have.
Wonderful. Thank you so much, Dr. Burns. We actually did receive a tremendous amount of questions from a variety of topic areas. So I'm just going to kind of organize them back to how you presented. And so we'll kind of hone in on specific ones about the diagnosis. And this one in particular, I find most interesting, just because I know you mentioned in the beginning of the presentation that Parkinson's disease tend to affect mostly men. However, we have seen women in PD. And so this particular question is of a woman with Parkinson's disease. And she asked, my PD diagnosis was delayed because of a significant overlap of my symptoms with menopause. This included constipation, bloating, frozen shoulder, brain fog, etc. Are there any expert clinicians that specialize in menopause and Parkinson's disease and how it relates?
You know, that's an excellent question. So I'm not familiar with subspecialists who focus on that combination of symptoms. And I think the relationship between the estrous cycle and menopause and Parkinson's is poorly understood. So I will say, just from personal experience, I've had several patients, young onset Parkinson's patients, who describe cycling of their symptoms associated with their menstrual cycle. Why that's the case, I don't think it's well understood. But I will say that many patients' symptoms that you've described will often delay a diagnosis. So, for example, we will often have patients who have some ostensible orthopedic problem, knee pain or shoulder pain, that where they see an orthopedist, sometimes they'll get a surgery that doesn't resolve the symptoms, and only then will the orthopedist say, oh, you know what, this may not be primarily orthopedic. So, that person's experience is not uncommon. Often patients will see a GI doc first or orthopedic doc first before coming to us. So you're not alone in having that experience, I'm afraid. And I wish there was a better understanding about the relationship between menopause and Parkinson's. Currently, there's not.
And it's interesting you mentioned about delayed diagnosis, because again, you see some of these symptoms. Is it part of age, or is it part of a previous injury, or what have you? Multitude of factors that play into, why an individual delay or even seek, opinion in a specialist, specifically movement disorder. And so, with someone who may not fall into the general, age group for Parkinson's diagnosis. We're speaking about young onset Parkinson's disease. We got a question from one of our viewer who says that he was recently diagnosed with young onset Parkinson's disease. And is there a way to discern physical symptoms that are a result of Parkinson's disease and not just the effects of getting older, like pain, aching, soreness, and loss of strength?
Yeah. So my general approach in these sort of situations, whether it's young onset Parkinson's or not, is if there's a new symptom or a symptom that's bothersome or impairing, you should presume that it's Parkinson's related until proven otherwise. And the way in which you assess whether it's Parkinson's related is often to see if there's a clear correlation between that particular symptom and the medication dosing. So I have a lot of patients who say, you know what, I don't have the same energy I used to, or I have this back pain, but I'm getting older and that's how it is. And then I'll say, well, does the back pain get any better an hour after you take your carbidopa levodopa? Does it get worse if you ever late on a dose? And they'll say, well, you know what, actually, there does seem to be this relationship to meds. And then turns out that it's a Parkinson's related symptom. I think that there's been a growing appreciation for the non-motor symptoms or the breadth of symptoms that are associated with Parkinson's, but still, I think these sorts of the things that aren't tremor, slowness, and stiffness can be missed. And so if you're wondering, I've noticed these things, is it just me getting older or is this the disease? I think the first question you should ask is, does this particular symptom track with my meds? Does it get better after I take my meds? Does it get worse? Is it worse first thing in the morning before I take my first med, or does it get worse if I'm late on a dose? Is there that relationship? That might give you a first clue.
Thank you. And you talked about, the importance of exercise. And we hear this time and time again for all sorts of chronic diseases out there, how the impact and the positive effect of exercising. So given how exercise can slow the progression of Parkinson's disease, does that mean that sedentary people are more likely to be diagnosed than very active people? And does the intensity of the exercise have more impact?
So yeah, so regular exercise is thought to be preventative. So people who exercise regularly have a lower incidence of Parkinson's disease. It's hard to know whether that's true, specifically of Parkinson's, because the effect of exercise has broad beneficial effects. But the type of exercise that has been studied in Parkinson's disease to be beneficial is what's generally thought to be what's called zone 2 exercise. So this is, as I said, light to moderate type of exercise, where you can still more or less hold a conversation. The reason, the sort of mechanistic reason for that is that form of exercise is the exercise that helps your brain make more mitochondria, which is the part of the cell that generates energy. Synuclein, alpha-synuclein, the protein I mentioned to you before, is thought to impair the normal function of mitochondria. And because the dopaminergic cells that make dopamine for the brain are a high metabolic rate type of cell, they're firing regularly, they're making a lot of dopamine. Any metabolic injury to those cells puts them at risk of malfunctioning and dying. And so if you can do a form of exercise that helps make more mitochondria, then that helps the remaining dopaminergic cells maintain good energy, maintain good mitochondria. And so if you want to be technical about it, you want to do at least 30 or 40 minutes a day of exercise where your blood lactate level stays under 1.9, but most people don't have blood lactate meters. And really, it's just as good a measure to that sort of talking on the phone measure. And so it's sort of steady state, mild to moderate exercise. That's the thing that has the most evidence base.
Yes,
And that benefit adds up slowly over time, months and years. So that's why you want to make a habit of it. But it can make a significant difference.
absolutely. And for most of you guys, asking and wondering about the types of exercise, the Parkinson Foundation does have an exercise recommendation in terms of, like, as Dr. Burns mentioned, from yoga, Tai Chi to amazing cardio and lifting. And so we do have an exercise recommendation sheet. I'm going to ask my colleague Laura if she can plug it in on the chat for you all. But this is a great reference, great starting point. And keep in mind, all at your level, we all are coming in and approaching exercise at a different point with Parkinson's disease. So keep in mind, have a great conversation with your provider, especially your movement disorder, just to make sure that you explore these type of exercise with care and cautious. And then one of the questions we did get in terms of exercise also, pain. I'm sure you've heard this a lot with your patients dealing with pain, dystonia, and how challenging it is for them to even do exercise. What is your recommendation for them?
Yeah, so a couple of things. As far as treating the pain, I think that pain can be a Parkinson's symptom, and you want to at least explore the possibility of dosing the carbidopa levodopa or your other medications at sufficient levels to manage that pain. So for some people, they may not have significant tremor, slowness, or stiffness, and pain is the main symptom. And it's not until you get to an adequate dose of carbidopa levodopa that the pain is managed. That may not be sufficient management for pain. And so when it's not, Botox often is used as a supplemental therapy. So the same stuff that celebrities use for their wrinkles can be very effective at loosening the muscles that can cramp in Parkinson's disease. And that particular kind of cramping is called dystonia. And it can produce abnormal posturing of the neck, hands, or feet, sometimes in the back. And so if there's a localized area of pain, Botox injections can be effective. When the combination of carbidopa levodopa and Botox is not sufficient, then you want to see a pain management specialist. And often the goal there is to treat the residual pain with non-narcotic based therapies. Some of that can be muscle relaxants or massage. There are a variety of options, but usually it's a multidisciplinary and multi-therapy approach. And then even if that pain or that dystonia is limiting certain forms of exercise, you should explore other types that you can do safely and more comfortably. So you don't have to go jogging. You don't have to ride a bike. You can try and explore other types of exercise because the form of exercise doesn't matter. The goal is just doing something you enjoy on a regular basis at that sort of mild to moderate level of exertion.
And you talked about taking the medication to help alleviate, in addition to exploring alternative approaches like Botox. We got a great question, and I think this is something really important to bring up and worth mentioning. Does the medication have to be taken at the same time every day?
Yeah, so sort of yes and no. So I would say when you're first seeing a clinician and you're trying to get a sense of how the medications are going to work for you, how much med you're going to need and how frequently, you do have to be kind of Catholic about it. And that's because you want to stick to a regimen for a couple of weeks so that you can get a clear sense of, is this amount the right amount for me? Is this too much or too little? When is it wearing off? What times of day do I need to take an extra med or shorten the interval between meds? Or going back to exercise, I have some patients who say, my regimen is fine, but if I go to rock steady boxing or if I go on a jog, then my meds wear off real quick. But so sticking to a schedule helps you figure that stuff out. Once you figure that out, once you have a schedule that works for you and you know when you might need an extra pill, then you can be flexible. Because again, the goal is just managing the symptoms you care about. So I have some patients where we've gone through this process of figuring out what works, what schedule, what dosing. At that point, I tell them, they can audibilize, they can take an extra pill here or shorten the interval there if they need it, if they're going out to dinner or if they're staying home. And then at that point, it's okay to be more flexible. That tends to be how I approach how regimented to be about meds.
And do you find that can someone become tolerant with the Parkinson's disease medication?
So not in the way that people become tolerant to benzodiazepines or alcohol or other substances. People over time, because disease progresses, may need more meds or more frequent meds, but that's not because of the meds they took before. It's because the underlying disease progresses. And that rate of progression happens regardless of whether you're taking meds or not. So why am I so confident about that? It's because there have been large studies that have compared, as I mentioned before, compared large groups of patients who have Parkinson's disease, some of them who started taking meds early, right at the beginning when they first got diagnosed, and other groups of people who waited before they started taking meds. And in each of those groups, there's no difference in when they started getting complications, how much med they ended up on in a year or two. There was no difference in side effects or amount of meds or anything, whether they started early or late. Now, if the med itself caused dependence, then you would expect the people who started the med early would need more med and would have more complications, but that wasn't the case. And so the med itself doesn't cause a dependence the way other classes of drugs do.
And just a reminder, because I know, again, this is a Parkinson's disease 101, and we're kind of reviewing the basics, foundation of what you should know about Parkinson's disease. So as you mentioned about the Parkinson's disease medication and the importance of taking it every day, every time, during the same time, how about with taking with food? Is there a certain type of specific food that you should not take, or with?
Yeah. So for some patients, and I may be saying this a lot over the question and answer session, for some patients, the food makes a big difference. So I would say for maybe 15 or 20% of patients, what they'll tend to notice is that if they eat a high protein meal, that high protein meal blocks absorption of the medications. And they'll notice that the meds don't kick in, or they don't last as long, or they don't kick in as much as they normally do if they take the med on an empty stomach. Many patients don't notice any relationship. They can take the meds, eat a hamburger, there's no effect. And so what I would tend to say is don't limit your diet and start restricting what you eat or when you eat unless you notice that clear pattern. So if you don't notice, and that's why at the beginning of a treatment regimen, you want to stick to a clear pattern so you can notice these kinds of things. So if you are taking your meds regularly and you don't notice any association between eating a turkey sandwich and how well the meds work, then you don't have to worry about that. But for that maybe 20% of patients where there is a relationship, you'll notice it if you're sticking to a clear pattern, and then you can make adjustments. And it's usually the protein load, the amount of protein in a meal that affects the med.
Wonderful. And always have a candid conversation with your provider about medications, concerns, questions, changes. I think this is something very important for both care partner as well as the individual with Parkinson's disease, is to keep log of any changes, any, what feels normal, not normal, because it's really helpful and useful for their provider to fully understand the impact that these medications are having. So I appreciate that. So now we're going to shift a little bit more because you talked about the different types of symptoms.
Mhm.
And interestingly enough, we received many questions and interest in learning more about tremors. And so some of the questions that we received were, and this is a two-part question.
Mhm.
Why do some people with Parkinson's have a resting tremor while others don't? And does Parkinson without tremor progress faster than with tremor?
So it's not well understood why some people develop a Parkinsonian tremor and other Parkinson's patients have no tremor at all. That's just sort of the easy answer to that. Not well understood. Moreover, I would say about a third of tremor predominant Parkinson's patients don't get good response from the carbidopa levodopa. So, and that's why that's the case is not well understood either. But I have some patients who their slowness, their stiffness, some of their other Parkinsonian symptoms respond well to meds, but the tremor is really not well captured by the meds, even at higher doses. So, so that I don't have a good answer for, but that is a pattern that I see. There's some debate about different Parkinsonian subtypes and what those subtypes mean as far as prognosis. So sometimes docs will talk about a tremor predominant Parkinson's disease or an akinetic rigid subtype or a balance predominant subtype. And historically, it's been thought that those different subtypes progress differently. um, it, I don't know of any strong evidence, sort of rigorous research to back that up. That's sort of a, like some clinicians have that impression, but I think that that impression is muddied somewhat by what are called atypical Parkinsonisms, which are sort of cousins of Parkinson's disease. You can think of them that way, but they're different diseases. Diseases like dementia with Lewy body or progressive supranuclear palsy or multiple system atrophy. These diseases have some Parkinsonism. People are slow and stiff, but they tend not to have the same kind of classic tremor. And they tend not to respond as well to meds. They also tend to progress more quickly. So why am I telling you about all of these other diseases? It's because the clinician's impression of these different subtypes may be muddied by the fact that some of the non-tremor dominant Parkinson's patients may actually have these other diseases. And so the clinician's impression about rates of progression may be because these other diseases progress more quickly, not because a particular subtype of Parkinson's progresses more quickly. So it's a debated topic in the field.
Yeah, and we obviously received several interests in that topic about tremors, so I
Yeah.
appreciate you answering it at the best that you can. So one of the other things we received was about sleep disorder and the disruption of sleep and getting good quality of sleep, which now affects the excessive daytime sleeping.
Yep.
What advice can you provide for individuals who encounter these issue with sleep disorder, and then of course with the excessive sleeping?
Yeah. So sleep hygiene, I think, is important because it affects many of the other symptoms that people care about. So it affects how well the meds work during the day. It affects alertness, cognitive symptoms. It affects constipation, all kinds of things. And so I would say the first thing to do is try and get some sort of sleep assessment, get a sense of, and that's not just for snoring. So a normal sleep study will give you a sense of how efficient your sleeping is. Some of the wrist watches you can buy now give you a kind of a basic summary of that. But a sleep study will give you a sense of how much REM sleep you're getting, how much deep wave sleep you're getting, what's the quality of the sleep. Because often when people go to sleep, they don't have a sense of how that goes. They just wake up the next day. If they were in bed for 8 hours, they say, well, I must have been good sleep. I don't know why I'm tired. When in fact, your sleep is disrupted in many ways you don't yourself remember. And a sleep study is a good way of getting a sense of that. And then once you have that information and you can share that information with your Parkinson's doc, then there are a couple of treatment options. One may be just take a long-acting carbidopa levodopa overnight. It may be that your Parkinson's symptoms are waking you up, even if you don't quite remember waking up. and then that can improve your quality of sleep. There are other sleep-related medications that can be very effective. Sometimes a CPAP can make a difference if you're snoring. So you want to start there. And for the sleep evaluation, you're likely going to have a conversation with a sleep doc about sleep hygiene. So trying to avoid a bunch of napping during the day, trying to consolidate sleep at night, having a regular bedtime and wake up time, no screens in the bedroom, that's phones and televisions and computers, keeping the room dark and quiet and cold, all that stuff, which makes a big difference. And then treating urinary symptoms that disrupt sleep is a big deal. And increasingly, there are effective meds for that. But usually it starts with modifying fluid intake within a certain amount of time around bedtime. And then there are some medications that can help with frequent urination at night. So I would say that would be the sort of complete approach. And you want to be aggressive about managing this stuff. You don't want to be a tough guy about sleep and just say, well, I'll just deal with it. It can make a huge difference as far as your symptoms, your mood, how well the meds work. So you want to take that part of your care seriously.
And I want to kind of wrap this up because we are approaching close to our time. But I think some of the most important piece in the role of managing care with Parkinson's disease is also the role of a care partner.
Yes.
And we did get a great question from a care partner in terms of determining the best care for their loved one with Parkinson's disease, ensuring that, the neurologist, as well as, what they're doing, that they're doing everything that they possibly could do to improving, the care for and managing the care for Parkinson's disease, and how often they should see a movement disorder specialist, and if there's other therapies, treatments that they should be exploring, in addition to, your basic gold standard treatment of Parkinson's disease.
Yeah. Yeah. So I'd say a couple things about a caregiver. I would say a caregiver should feel emboldened in the clinic room to bring up stuff that their partner doesn't. I see this a lot in various settings, but you want to be an advocate for the person you're looking after and bring up stuff that they've forgotten or maybe they're uncomfortable to mention. And so that's one thing. And to some extent, the electronic medical record system helps this a little bit. You can set up in the Epic system, a MyChart account and send a message to the provider on behalf of your spouse or your loved one, as long as they're comfortable with that. That might be a good way of bringing up additional issues. You should also absolutely feel comfortable seeing a couple different docs, to get a sense of different perspectives or access to different resources, so that you feel like you're exploring all the care that is available. As far as how frequently to see doctors, probably at the beginning when you're first working out the medication regimen, every couple months, every 3 to 6 months makes sense. And often I will be corresponding with patients over MyChart more frequently to say, okay, you've tried this for 2 weeks, now make this dosing adjustment or add this medication. We'll do that over the MyChart system in between visits. So that often happens at the beginning. And then over time, if you come to a steady regimen, then that can be stretched out to once a year, unless something comes up and it can be made more frequent. But that's, I think that's often a pattern that I see. I would say with regard to caregiver advocacy, there are a couple types of symptoms I think that affect people's quality of life a lot, and people are a little reticent to talk about. So cognition, for one, mood as another, and not just depression, but agitation, anxiety, apathy, and then sex. So these are absolutely things that you should be bringing up with your Parkinson's disease doctor. If that doctor isn't comfortable talking about those issues, then you should find a different doctor. These are quality of life issues. They are as important as tremor, slowness, and stiffness. And there are effective therapies for all of these things. So, you should think of your Parkinson's doc as almost a primary care doctor, in that they should be managing these other things, which are associated with Parkinson's disease and affect people's quality of life. So I'll
Thank
get
you
off my
so
soapbox
much.
now, but I think those,
No, absolutely.
reemphasize those things in particular, because often I've got patients who, to be honest, they could care less about their tremor, but their Cialis makes a big difference in their life, or their Fixel, the med that helps their anxiety, helps them get in the car and go to dinner with their, that's a real quality of life issue, and you want to be forthright with your doc and be aggressive about treating that stuff.
Absolutely. No, thank you so much for sharing those, real life experiences with your patients, and especially the role of a care partner, advocacy. I feel like they're both synonymous to one another, and it's it's a way to receiving the most appropriate and care, advanced care for your loved one is just asking those questions,
Yep.
and getting the answers, and it really relieves all the stress, and burden that a care partner may have.
Yep.
And that's the goal, right? To minimize all the stress and concerns you may have. And it's just by asking those questions, and no question is big or small or uncomfortable. You just got to ask them to get it
Yeah,
addressed.
and if you're in a situation where you bring up one of these things and the doc is awkward about it or doesn't do, that's their fault. That's not your fault. That's their problem. Docs are humans too, and sometimes they're not so good at. So that's on them. That's their problem. You go find somebody better.
Yeah.
Don't think any more about it.
Thank you so much. Well, thank you, Dr. Burns, so much for sharing your expertise, your time today,
Sure.
answering the amazing questions that we got from our participants. And I also want to thank all of you guys who joined us today to learn about the basic and overview of Parkinson's disease. We hope you were able to walk away with some new information. And we do apologize if we didn't get to all of the questions. We do encourage you to reach out to our amazing helpline team at 1-800-4PD-INFO, and they'll be more than happy to address your questions, or even direct them to those specifically that could help address those, specific medication, or looking for referrals, or again, maybe you want to find a new movement disorder specialist. Again, our helpline is more than willing to help you and assist you with those questions you have. As we close today's program, I do want to share a brief, program with our next Wellness Wednesday program, which will be Wednesday, October 30th, on gene and cell-based therapies in Parkinson's. This webinar will review the basics of gene and cell-based therapies. We will discuss what these therapies may or may not accomplish for the person with Parkinson's, as well as what to expect in terms of treatment process. So to find out more and register for our PD Health at Home programs, you can visit parkinson.org/PD Health. As a reminder, we want to take this moment to thank our program sponsor, Biogen's Luma Study. Thank you again for your support of the Parkinson's Foundation mission. And as I mentioned before, we have an amazing helpline team readily available to answer your questions. But more importantly, if you're looking for resources or would like to obtain copies of materials that we have on our webpage, you can also request that with our helpline team. Again, that number is 1-800-4PD-INFO, or you can email them at helpline@parkinson.org. And before we end today's webinar, your Zoom screen will prompt a survey, and this really helps us to get that feedback, and helps us really formalize our programs in the future that best suits your needs and interests that you have as it relates to Parkinson's. So please take a couple minutes to complete that survey, as it helps us to develop future programs that meet your needs. We thank you so much for joining us, and we hope you stay tuned for our next program. Have a wonderful day.